Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues and PGs, today we shall discuss the new treatment algorithm for chronic hepatitis B in the light of recently published guidelines, that is the Chinese guidelines published last year and WHO guidelines published on 29th March this year. And this is in accordance with the WHO target of 2030 for hepatitis elimination from the world. This algorithm has expanded the eligibility for starting antiviral treatment, as well as it has simplified the steps for initiation of the antiviral treatment. As mentioned in the intro, today's discussion will be on the new treatment algorithm for hepatitis B. We have noticed a plethora of guidelines over the last 1 decade or so. At least one new guidelines per year by one of the 4 major bodies of the liver in the world: AACD, EASL, APASL, and WHO. And the reason of these so many guidelines is that it has remained a very difficult question in the clinical practice that if a patient is having chronic hepatitis B, so when to start antiviral treatment and when to stop antiviral treatment. But in 2024, we are seeing a paradigm shift of 180-degree in the light of recently published 2 international guidelines, that is the Chinese 2023 and WHO 2024 guidelines, in an attempt to achieve 2030 target of hepatitis elimination from the world. As mentioned, last year, Chinese published their guidelines for the prevention and treatment of chronic hepatitis B, and this year on 29th March, WHO published its guideline for the prevention, diagnosis, care, and treatment for people with chronic hepatitis B infection. If we see the algorithm proposed by Chinese, and what they say, when a patient is found to be having HBs antigen positive, then before doing the PCR, look for the peculiar scenarios if the patient has got that. And what are these peculiar scenarios? If the patient has got liver cirrhosis, if the patient has got liver failure, if patient has got HCC, or if the patient has got liver transplantation, he has got liver transplanted, or if the patient is going to receive chemotherapy, targeted therapy, or immunosuppressant therapy for any indications, or if the patient is going to receive DAA's treatment for hepatitis C infection, then this patient needs antiviral treatment and no PCR. If a patient with positive HBs antigen doesn't have these peculiar scenarios, then you check the PCR. And WHO is recommending the qualitative PCR, not the quantitative PCR. So what they say, check the qualitative PCR. If it is undetected, that is negative, then you do the follow-up every 6 to 12 months. But if the PCR is detected or positive, then decide according to the ALT levels. If the ALT is normal or less than normal, so if such patient has got one of the following situations like family history of hepatitis B related cirrhosis or HCC, or age is more than 30 years, or there is non-invasive or histological examination showing significant inflammation, G2 or more, or fibrosis, F2 or more, or if this patient has got HBV-related extrahepatic manifestation. So with positive PCR, normal ALT, and having one of these scenarios, you start this patient on treatment. Otherwise, in the absence of these 4 situations, you follow up every 6 to 12 months. Then the other part is if the patient has got positive PCR and the ALT is elevated, irrespective of the folds, 1.5 or 2 times, just elevated, then exclude other causes of ALT elevation. And when there is no other causes of elevation like HCV or NASH or metabolic liver disease, then you start this patient on antiviral treatment. So, point to consider is that patients having HBs antigen positivity, we should look for these specific scenarios and then start the treatment without doing PCR. And second point, when these scenarios are not met, these are not present, then you check the PCR only then, and the Chinese recommend the qualitative PCR. And with positive PCR in the raised ALT, you start the patient on antiviral treatment, but with positive PCR, is the ALT is normal, then you look for these 4 scenarios, and if any one of these is present, then you start this patient on treatment. These are the Chinese 2023 guidelines algorithm. What about WHO? The WHO gives 4 scenarios. And it says, treat all adults and adolescents aged more than 12 years, including pregnant and non-pregnant women and girls of reproductive age. And what are these 4 scenarios? First scenario is, if a patient has got significant fibrosis, that is F2 or more, or cirrhosis F4, then regardless of the HBV DNA or ALT, you start this patient on treatment. And for clinical criteria for cirrhosis should be there. And in the absence of the clinical criteria for cirrhosis, then the non-invasive tests like EPRI having more than 0.5 or transit elastography having more than 7 kilopascals for adults. So the first treatment option, the patient with significant fibrosis or cirrhosis. Second treatment option is when the HBV DNA level is more than 2000 units and ALT is elevated. Again, start this patient on treatment. Third is when there is the presence of any of the following, regardless of the EPRI score, HBV DNA or ALT levels. So, co-infection with HIV, HDV, and HCV, family history of the liver cancer or cirrhosis, if there is any immunosuppressions to be given to the patients, or if there is comorbidities like diabetes, metabolic dysfunctions, associated steatotic liver disease, or if there is extrahepatic manifestations, there is a glomerulonephritis or vasculitis. This is the third group where treatment should be initiated. And the fourth is that if there is persistently abnormal ALT levels alone in the absence of access to HBV DNA. So if we think and if we look into these 4 options in a deep, so what we say, what we find, then PCR is required only for the second option. When the patient has got significant fibrosis or cirrhosis, patient has to be treated. If the patient has got any of these special situations, patient has to be treated. And if the patient has got persistently abnormal ALT levels, then what the WHO recommends that you should start this patient on treatment even if the PCR is not done or if it is not available. So when a PCR is not available, you can presume in 50% it will be positive, in 50% it may be negative. And In the absence of all these, when the ALT is normal, DNA is less than 2000, then they say, and there is no special scenarios, then you defer treatment and do the follow-ups. I'll convert this 4 options algorithm into the one which is similar to the Chinese, and this is purely what I'm doing. I'm converting these 4 options into this algorithm so we compare the Chinese and the WHO more easily. So according to the Chinese, if a patient has got HbS antigen positive, then if the patient has got significant fibrosis or cirrhosis, this has been the first option. Or the patient has got co-infection with HIV, HDV, HCV, or family history of liver cancer and cirrhosis, or if there is immune suppression or comorbidities like diabetes or extrahepatic manifestation. This is option number 3. So in the case of option number 1 and option number 3, start this patient on antiviral treatment without doing the PCR. Is it clear? Now, if these scenarios are not present, then you do the PCR, and the PCR, the WHO recommends to do the HBV viral load, quantitative PCR. If this quantitative PCR is less than 2000 normal, ALT is normal, then defer the treatment and monitor, and this is this option. DNA level less than 2000, ALT normal, no specific situation, then you start this patient, you do follow-ups and don't start this patient on treatment. This one. When the viral load is less than 2000, but the ALT is raised, you start this patient on treatment. It is this option. ALT persistently raised. The threshold for starting antiviral treatment in case of normal liver and no peculiar situations, it is the viral load more than 2000 and ALT normal, more than normal. So WHO says even if PCR cannot be done, or we can say if it is done in less than 2000 even, and the ALT is persistently raised, so you start this patient on treatment. And this, I convert that into this form. And when the viral load is more than 2000, ALT is raised, you start this patient on treatment. And of course, even if the ALT is normal, what to do here? WHO guidelines are silent over here. So this is the WHO, the Chinese guidelines, the same pattern. Patient HbS antigen positive, look for these peculiar situations. These are not present, then do the PCR, the qualitative PCR, and then undetected, detected, undetected, don't treat, detected, ALT raised, treat, ALT normal, look for these 4 scenarios and then treat. WHO is saying, again, HbS positive, look for these situations, and if you can judge it, that the scenarios for which the PCR was required to be detected, these 4 scenarios, WHO has taken these 4 scenarios into this group, that even in these 4 scenarios, PCR is not required. So this is a paradigm shift. And then because they are doing the quantitative PCR, so check for the viral load and the less than 2000, more than 2000. This is what I was saying, that there is a paradigm shift. But I will move one step further, one step ahead. We know the clinical guidelines, these are tools of management, not rules of management. So, but I will suggest a hybrid treatment algorithm. This is being in my clinical practice for many years, especially in few specific or special individualized cases. But the availability of these 2 guidelines, they have given me the chance to share that with you as well. And this is more logical and this is more inclusive and it expanded the eligibility of starting antiviral treatment. Point is, when a patient comes to you with HBs antigen positive report in his or her head, what you do? First aim is of the antiviral treatment is to prevent reactivation of HBV infection. So, if a patient is receiving chemotherapy, targeted therapy, or immunosuppressant therapy, or if the patient has undergone liver transplant, these are the two scenarios where you start this patient on antiviral treatment and not do the PCR. PCR is not required over here. And the WHO has taken this, and WHO has said that the PCR is not required over here. Though the Chinese guidelines, they said that the PCR should be detected, but the WHO has removed the need for doing PCR. So even with negative PCR, treatment is required in these patients. So to me, if a patient has got HBs antigen positive report, and if the patient is going to receive chemotherapy, targeted therapy, immune therapy, or if the patient is liver transplant, I will give antiviral treatment to prevent reactivation of the HBV infection. Second scenario is if there is extrahepatic manifestation. This indication was kept in the Chinese where the PCR was required, but the WHO says no PCR required. And the same is for co-infection with HIV, or if there is family history of liver cancer or cirrhosis, or if there is comorbidities like diabetes and MASLD. These are the scenarios where WHO says that this patient needs antiviral treatment. Then, according to the liver status, if it's a liver cirrhosis, F4, significant fibrosis, F2 or F3, if the patient has got HCC or liver failure, again, this patient needs antiviral treatment. And both the guidelines agree on it, Chinese and the WHO. The one point is that the Chinese say if there is liver cirrhosis or significant fibrosis, you need a PCR to be to do, and it should be positive. The WHO says that PCR is not required over here. The seventh indication where HBs antigen positive and the antiviral treatment is required is the raised serum ALT levels. And this is according to the WHO guidelines. As I mentioned, WHO says that persistently raised serum ALT levels when no other cause could be found, and even there is no access to the PCR, start this patient on treatment. So practically to me, HBs antigen positive with persistently raised serum ALT levels, no other cause could be found, start this patient on antiviral treatment. So if a patient has any one of these scenarios, the patient needs antiviral treatment. In the absence of these 7 scenarios, what we should do the PCR. In fact, I will take the recommendation, I'll follow the recommendation of the Chinese guidelines, that is when they say you should do the HBV qualitative PCR. So, depending upon the report of the qualitative PCR, and remember, I am doing qualitative PCR in case that the patient has got HBs antigen positive and no these scenarios are present and the ALT is normal. Because if the ALT was raised, I had to start that patient on treatment. So, HBs antigen positive and normal ALT. I am doing the qualitative PCR, and depending upon the qualitative PCR, whether this is detected or not detected, I'll proceed further. How? The qualitative PCR positive detected, I'll treat that patient. So, HBs antigen positive, normal ALT, qualitative PCR detected, treat that patient. What about that, where the PCR is not detected? So, normal ALT, PCR not detected, but if the age is more than 30 years, or if the patient has got co-infection with hepatitis C or D, so at least during that treatment duration when the patient is getting treatment for hepatitis C or hepatitis D. So during that treatment and 3 to 6 months after the end of that C or D treatment, I will treat this patient. But if the patient has got more than 30 years age, again, I'll treat that patient even with the negative PCR. Patient PCR is negative and the patient is young and there is no co-infection with C or D, so I will not treat that patient and I'll do the follow-up of this patient. So this is the hybrid treatment algorithm, which more or less I was following in my clinical practice for many years. But now when these two guidelines, the Chinese guidelines and the WHO guidelines are in my hand, it gives me an opportunity to share my thoughts on it. And this is more logical. And this is in accordance with these two guidelines. The easy points are easy portion in both guidelines. I have taken those and make a hybrid treatment algorithm. And this I will suggest that following this treatment algorithm, it will be easy to start antiviral treatment and more patients will be included in the treatment group. So HBs antigen positive, look for these 7 scenarios. One is to prevent the reactivation of HBV infection. Second is extrahepatic manifestation, co-infection, family history, comorbidities, liver status, and raised ALT. When these are not present, ALT is normal, then do the qualitative PCR, detected, treat, not detected, then if the patient is more than 30 years of age, co-infection C and D, treat, otherwise you don't treat and you do the follow-up of these patients. I hope with this new treatment algorithm, we will be including more and more patients and we will move faster towards the WHO 2030 guidelines of hepatitis elimination from the world. I end here. Thank you very much for watching. And if there are any comments, any queries, please do share in the comments of this video and I will try to answer that. Khuda Hafiz.